Hello everyone, welcome back again. It's good to have you all here. Welcome to Grapharm Academy. This week we are handling different series on the gastrointestinal disorders. We have a lecture that we have just had on peptic ulcer disease. Kindly log into that so that you would appreciate everything about the peptic ulcer disease. So today I'm going to look at what we call the esophageal or gastroesophageal reflux disease, and we see that this specific condition is common when there is a disorder with a GI motility, and when there is acidity of the gastric content, and then we see that it's also most common then when there is acid content reflux back, we know that what the specific organ in the stomach that prepares or that secretes acid is the stomach. So when there is a reflux, we call it acid content reflux. It can get back to the esophagus, and your patient maybe when it is starting would present with heartburn. Then you can also have intense burning or sometimes belching. Yeah, we can have people belch, and I think this is not a new term. Most of us have experienced belching. Can also lead to esophagitis, that is inflammation of the lining of the esophagus or the layer of the esophagus. And then you can also have esophageal ulcer and then strictures at their esophagus. We see that your patient as well will have the gastroesophageal reflux disease. Should advise your patient on the life change. That's avoidance of excess alcohol and the food such as fat. So other measures that you may encourage your patient, that is induce weight reduction if they are obese, and they should stop smoking in case they are smoking, and then there should be raising the head of the bed, like you make sure that maybe the patient or the person sleeps with a pillow raised or with a pillow here, or their bed can be raised. We know that the hospital beds are always adjustable. So what are some of the mild symptoms that your patient would present? So we see that GERD is not so complex in a way that it can present with a few symptoms that we have seen, that belching may be there, maybe heartburn the patient may have, maybe we need the patient should sleep right, the patient may need to reduce weight, this patient should stop smoking. So you find that it is not a big condition, but you find you need to be aware of it, because most of us are suffering from it unknowingly. So the management that you'd consider, since it is the acid that has been refluxed, you need what we call the antacids. Or we can also take the alginates as another class of medication. You may also need histamine receptors antagonists. We know that histamine receptors are distributed in the gastrointestinal tract, and majorly the H2 receptors or the histamine 2 receptors. We should appreciate that histamines have 5 receptors: histamine 1, 2, 3, and up to 5. But the most common ones that we have well distributed are the histamine 1 and 2. So we have drugs that manage these histamine compounds. Histamine is like a hormone that is synthesized in the body, and sometimes we need to reduce overproduction of histamine so that we are able to manage and focus on handling a specific disorder that must have happened or taken place. We see that proton pump inhibitors sometimes also are used to give relief, and proton pump inhibitors, last lecture we looked at how the acid is secreted. So it is secreted through the potassium hydrogen pump. So if you block the potassium hydrogen pump, you are able to inhibit production of HCl, and once HCl release is reduced, the reflux is going to be reduced because the acid itself will be reduced. Yeah. So we can also, your patient may also have what we call dyspepsia, that it covers the upper abdominal pain. That's how it would present. You will have fullness, the person is full even when they have not maybe had a heavy meal. You can also have what we call the early satiety, you can have bloating, you have nausea. It can also occur with gastric and duodenal ulcer. Those are dyspepsia. What's the pharmacological management? So this pharmacological management is going to cover both management of peptic ulcer and management of the excuse me, sorry for that. Oh, sorry. So I was saying that this pharmacological management is going to cover both management of peptic ulcer and management of the gastroesophageal reflux. Yeah. So here we see that we want to focus on reduction of gastric acid. When we reduce gastric acid, we have histamine receptor antagonists, we have proton pump inhibitors, and we have anticholinergics. Then we can also look at mucosal protective agents. When we looked at the last lecture, we digested much how this what are the protective or the defensive mechanism of the mucosal membrane. What are the things that are produced? Yeah, so these are some of the drugs that we need to use. We have the sucralfate as a drug. We have prostaglandin analogs, and to be more specific, we have what we call misoprostol. Then we have bismuth containing compounds as another thing that you'd use. So if it's this acid production, excess acid production and erosion of that specific membrane is as a result of a bacteria. If it is as a result of bacteria, we need to give the patient antibacterials. And to be more specific, we have macrolides as an example, and then the nucleic acid synthesis inhibitors as another example. We need to appreciate that H. pylori or Helicobacter pylori is a gram-negative, and we see most cell wall synthesis inhibitors are not mostly effective for gram-negative bacteria. That's why we are not probably taking it as first line, or we may need it in combination therapy. For example, you may need penicillins, and to be more specific, you may need amoxicillin, or your patient may use amoxicillin. But in case you suspect any resistance from the bacteria, you may need to use a macrolide. Macrolide is actually very effective. And then you can take the nucleic acid synthesis inhibitor, which is our metronidazole. Yes. So why would we treat? Why would we need to know which medications to use? We need to treat our patients to relieve pain. Some of them are vomiting in this specific condition, maybe because of irritation of the gut. So it brings about the vomiting reflex, and that makes your patient to vomit. Then also blood loss. We saw that some of the things that would occur is bleeding. So we don't want the patient to lose a lot of blood as a result of this erosion of this. So we try to manage, and we try to eradicate the signs to eliminate the source of the problem. So we see that the proton pump inhibitors are directly inhibiting excess production of HCl. So you find it is very relevant and very useful to prevent recurrent or recurrence of the ulcer by the maintaining therapy. Sometimes we get ulcer, and then when we are given this medication, we are not compliant to it. And if we are not compliant to medication treatment, we find that your patient is going to suffer from reoccurrence of this medication. So always advise your patients to take full dose, and before you treat, know the real cause. Is it as a result of H. pylori, or it is as a result of NSAID use, or is it as a result of maybe stress? Yeah, because your ulcer may not be maybe not only as a result of one thing. So you need to know the cause, so that when you're giving treatment, for example, if you give antibacterials for management of peptic ulcer or as combined therapy, you may see that your patient may not recover in case it is as a result of stress. Yeah, so you find that stress is not H. pylori is not involved, and if H. pylori is not involved, you find that you are actually going to the patient going to take the medication, and yet the bacteria is not there, and as a result you may also have resistance in a way that the next time your patient tries to take the same medication, resistance takes place, or the patient may not recover whenever they use that specific condition. You can also, another aim is to prevent complication of ulcer. We want to prevent the complication. We saw the different complications as bleeding, scar formation, dyspepsia as those complications. So we want to avoid those complications from coming up. We also look at promoting healing of ulcer. So we are looking at those drugs that inhibit acid production, and we say that one of it is antacids and simeticone. Sorry for that, simeticone. So we see what's the mechanism of action. Yeah, the weak bases. These specific antacids are weak bases. For example, magnesium trisilicate is a base. We have magnesium hydroxide is also a base. Another example of this you may have a combined therapy of magnesium and aluminium, where you have aluminium hydroxide and magnesium hydroxide can be your antacid that you can use for management. So you find that they are weak bases and they come in to neutralize the pH. They are coming in to support bicarbonate, that we have a natural defense mechanism in the body. Also, we see that it inhibits formation of pepsin. Okay, so we see that the pepsinogen is converted to pepsin at an acidic pH. So now, when we give your patient these drugs that are neutralizing the pH, you find that pepsinogen cannot be converted to pepsin, and as a result, you may find that a reduced production or concentration of pepsin. Alright, so some of the antacids, like I was saying, they are usually aluminum and magnesium compounds, and they give relief, and you find that they try to prevent, or they may not bring about, erosion of the gastro or esophageal reflux. Okay, so we know that this reflex, the acid can get back, and as a result, the acid can bring about erosion of those layers in that specific area where it is getting back. Yeah, and if we give these medications, we find that the reflux may be there when there is reduced concentration of the acid, and if there is reduced concentration of acid, we are not going to destroy the cells around the specific area. We see that they are also sometimes used in functional dyspepsia, but the evidence of benefit is uncertain for that specific functional dyspepsia. And we see that our antacids are best given when symptoms occur or are expected. When you expect the symptoms to come, you give your patient those medications. Yeah. So we have what we call sodium bicarbonate. We know that the defense mechanism in the body as bicarbonate. So when you add the bicarbonate, you are also still focusing on reducing the concentration. You are focusing on reducing the concentration of the acid. You are focusing on buffering that specific area. And buffering that specific area, you are looking at maintaining either the acidity and basic properties of that specific region. So we see that it is a nutrient or a potent neutralizing capacity and acts instantly. It is not used anymore for its demerits. You find it has some of the disadvantages, that is can bring about systemic alkalosis. It may bring about distension, can bring about discomfort. It may also include belching because of the carbon dioxide that's coming out. Okay, so you may not see this more often in the field. So mostly these days what we use is aluminum hydroxide, magnesium hydroxide, magnesium trisilicate. We see that our milk also contains magnesia. That's why sometimes we encourage our patients to take milk. Why? Because it has magnesium in it. And we have seen magnesium hydroxide comes in to help and neutralize the pH within the area. Magnesium carbonate indicated for dyspepsia, and we see that the duration of action of these specific conditions or drugs is 30 minutes when you give a patient, and most of them you can chew, like magnesium trisilicate. Sometimes when you leave it at the reach of children, you may find they have eaten it all. Why? Because it is sweet. So make sure that you keep medications away or out of reach of children, because when they find sweet ones, you will find they have overdosed themselves, and if the side effects that the drug gives are more, you may have an emergency case. So let's be very keen when we manage condition drugs and where we store them at home, so that we don't cause more problems for the young ones. Yeah, all medicines are toxins. Okay, the concentration of how much of the toxin you have taken in determines how it reacts. This doesn't mean that you stop giving your medications to patients or to people who need them. You give the recommended dose that is going to elicit response. Okay, so if it is not a recommended dose that's going to elicit response, then it can be bad. What are some of the side effects that we expect when we use this antacids? When we are using aluminum hydroxide, we see that the major side effects that your patient may experience with is what we call constipation. When you're using magnesium carbonate or magnesium hydroxide, you can see that your patient will develop diarrhea. So you find that most of the syrups we have combined, the manufacturers have combined both the magnesium and aluminum in a way that the diarrhea in aluminum manages the side effect of constipation that aluminum hydroxide would bring about. About magnesium trisilicate, we see that magnesium trisilicate also has a side effect of diarrhea. The person may also have belching. Magnesium antacids, we have osmotic diarrhea as another one. So we have the semiticon as another one that, as we had already mentioned. So we see that the side effect of this one, it decreases the surface tension, thereby reduces the bubble formation. And we see that as a result, it is used to prevent the reflux. Okay, then we have the alginates. Alginates are used as a protectants. We see that they may be useful in the gastroesophageal reflux, and we see that alginate is taken in combination with antacids. You don't take it alone. And its main mechanism is increasing the viscosity of the stomach contents and can protect the esophageal mucosa from acid reflux. Okay, so what are some of the therapeutic questions that you may have? You can say, is it irrational to combine aluminum hydroxide and magnesium hydroxide in an anti-acid preparation? I have just said, when we're looking at the side effects, we say that the side effect of aluminum hydroxide is constipation. The other for magnesium hydroxide is diarrhea. So it is actually rational to combine both of them, because if you give one at a time, you may find that the patient you have given magnesium hydroxide is going to have diarrhea. Aluminum hydroxide is going to have constipation, and you may need to use more other drugs to manage the constipation and manage diarrhea. Or what our patients may use or do, you find that your patient may move to another facility, and from there they are going to describe that they're having diarrhea or they are having constipation. And what that facility will do, they are going to treat the sign. Sometimes we don't give time to these patients to inquire more about what they are taking. Are there any conditions they are suffering? Are they on any medications? So it's really important for us to do so, because it's our role and responsibility, and it helps us to avoid what we call drug interaction. Okay, because if you are managing the patient based on what they are presented and you're not finding out what else they're allergic to, what is that they are already taking, what is their history of their health status, like in the past 1 month, what have they managed so far? In the past 2 months, what have they been managing? What is it that your patient has always presented with? And your patients are there and they will be in position to answer. Sometimes they don't feel like it is important to share all that information, so it is our responsibility to find out from them. So, how to avoid formation of insoluble complexes of drugs by antacids that are not absorbed. So we see that interaction can be avoided by taking antacid 2 hours before or after ingestion of other drugs, just like what I was saying. And we should aim at combination therapy, where you have magnesium hydroxide, aluminum hydroxide, or you can have a combination therapy when you are looking at reducing the normal bowel function. You still combine the two. The antacids can be in capsule form, can be tablet, can be powder form. That's why we see that magnesium trisilicate, it comes in a powder and you have to reconstitute. Reconstituting like is when you are given instruction to add water up to some mark and you ask them to shake always before use. They can come in a result of chewable tablets. Magnesium trisilicate tablets are chewable. Like I was saying, if you leave them out or you don't keep them right, your children will get them and they may take the whole tin in case you have a tin. Suspension can be in form of suspension. It can also have form of effervescence. We have omeprazole proton pump inhibitors that are in form of effervescence. Like you add it in water and you dissolve, like how you have juice, yeah. Maybe you have a sacket of juice and then you pour in a cup and add a specific amount of water. That's what we call effervescence. We have those medications that focus on protecting the mucosal membrane, and we have the sucralfate as one of them. And we see its mechanism of action. We see that in acidic pH, it polymerizes to give us a viscous gel that adheres to the ulcer, and that caters for majorly when we are handling the duodenal ulcer. So we see that this precipitate protein on the surface, and our proteins and act as a physical barrier. That's what we need to know about the mechanism. So you should take it on an empty stomach 1 hour before you eat your meals. Give these instructions to patients. Some of us forget to give this additional information to the patient. When you don't give this information, the patient is going to take after eating. And once a patient takes after eating and they don't get any relief after using the medication, what they will do, they will move to another facility and they will feel like for you, your medications are not working. That's actually what they will say. The uses NSAIDs induced ulcer. If patients with continued smoking, please come and they're presenting with this condition, you can give them the medication. And then topically, maybe the burn, in case there is burn, bed sore, ulcer. Sometimes when we lie down, there are those patients that are on chronic care, and they are always maybe admitted, and they take long, and some of them cannot get out of bed, so they end up getting this bed sore. So you may also recommend this medication for management of that. What are some of the adverse drug reactions that we may expect or that may arise as a result of use of this specific class of drug? We see that there is constipation, indigestion, flatulence, gastric discomfort may be another one. We have what we call colloidal bismuth as another medication that you may use, and it is majorly indicated for Helicobacter pylori eradication. And some of the side effects that you may have is the darkened tongue and the blackened feces. So your patient, after taking this colloidal bismuth, may start complaining over the tongue and the feces, so you have to tell them the truth. So the feces warning. Let's meet for the next lecture in a few minutes. Thank you so much for your time. We shall continue from here. Let me work on my power. Thank you. Subscribe to Grapharm Academy. Stay tuned with Grapharm Academy. Don't forget to subscribe, like, and share. Share with your friends, share with your classmates, and share with everyone around you, so that they all benefit from it. Thank you so much.